Today's episode is brought to you by DAX Copilot from Microsoft. DAX Copilot is an AI assistant that helps automate clinical documentation and workflow to let you be more efficient and reduce all the administrative burden that comes with patient care. To learn more about how DAX Copilot can help improve healthcare experiences for both you and your patients, visit aka.ms/knock-knock-hi. Again, that's aka.ms/knock-knock-hi.
Knock, knock, hi.
Hey everybody, welcome to Knock Knock I with me, your host, Dr. Glockenflecken. Thank you for joining me this fine evening or whatever time it is, wherever you are. This is your one-stop shop, all things eyeballs. If you've been going about your day doing whatever it is you're doing, and then after you got home from work, you're like, man, I could really just close out my day, start my evening, drift off to sleep with little eyeballs. Little eyeball knowledge, maybe not little eyeballs, normal sized eyeballs, but the knowledge is also just a little. I'm not going to overwhelm you, but you're in the right place. Here we go. I've got a few things. I've got another, you guys have been really enjoying the kind of mystery patients. I've got another patient to tell you about today. Not really a mystery, but an interesting new diagnosis that I made. And so we'll talk about that a little bit later. But here in the open, I want to just talk for a minute about Denver. We had a show in Denver, and we at the Denver Improv, which was awesome. Man, the costumes, people came out. You know, if I could redo this whole tour over again, we're now at the very end. We have one date left in Chicago next month. But if I could go back and do it all again, I would do bigger venues, because so many people wanted tickets, but they couldn't. There were only 370 or something for this venue, and we should have done more. You know, a couple of the places we went to had 600 or 700 seat venues, and even those were selling out. And so I apologize to all the people that tried to get tickets on this first go around, but couldn't because they sold out too quickly. We're doing more shows. All right. It's this Wife and Death tour. It's been so much fun to put on, to come and see audiences, to see the costumes you guys come in with. Lots of unicorn headbands. We got some radiology glasses, lots of scrub hats, just surgery attire, I should say. So it's been really fun to see that. Bicycle helmets, of course. There was a new one in Denver. Somebody showed up dressed as an eye drop bottle. They had a beanie hat. It was really tall. That was the color of, it was a dark blue cap, and then a white shirt that was basically the label of Cosopt, dorzolamide timolol. It's a glaucoma drop. She looked exactly like a human-sized Cosopt bottle. It was incredible. A+ for creativity. I took a picture with her. I forgot to post the picture, so I'm going to put that out there. So you'll see that if you follow me on Instagram, maybe Twitter, Blue Sky. I'm really enjoying Blue Sky lately. It's nice. It feels like early Twitter. And so anyway, I love that costume. I love everybody that comes in. I know how good an audience is going to be. It's based on how many costumes I see out there. And that's what's so fun about the small venues, the comedy clubs, because they're right there. It's there's engagement in the audience. You can feel the energy. It's awesome. So appreciate everybody for coming out. But one more thing I got to say about Denver, it is absurdly dry. I don't know why it still surprises me. I go to Denver every other year. I think last time I was there was when I gave the commencement address to the med school a couple years back. It always just blows me away how freaking dry that place is. The moisture just sucked out of my body, and you can't drink it. I don't know how people live there. How do you live in Denver? And by the way, like I know like everybody goes crazy of the Denver, the mountains. All right, let's just be honest here, people who live in Denver. Like if Denver didn't have mountains, it would be Iowa. Okay? Like let's be real here. Yeah, the mountains are beautiful, but Denver is just Iowa with mountains. That's what it is. And so, don't get too proud of yourselves for having beautiful mountains to look at. All right, I get it. It's great. Like better than cornfields, probably, sure. But I'm just saying, like other than the mountains, not a whole lot to look at in Denver. It's very flat, not a lot of vegetation, and it's dry as hell. So anyway, had a great time though. I really enjoyed it. I went to Meow Wolf. This is like this like hundreds of artists all came together to make this huge interactive. I don't even know how you describe it. It's not really a museum because you can touch everything and you can, but the only way you just have to go like go to the website, look at it. It's sensory overload is what it is. My kids loved it. We loved it too, but by the end, my head was just spinning, and just I felt like my eyeballs were getting sucked out of my head, just with all of the lights and the colors and the noises, and fascinating. Never experienced anything like it. Meow Wolf, go check it out. Okay. Before we take our first break, though, breaking news. This is what you come to Knock Knock Eye for, is breaking news, right? President-elect Trump has named his director of the Center for Medicare and Medicaid Services, CMS. And I thought this was a joke at first, but turns out it's true. It is Dr. Oz. Now, everybody's going to know this by the time you hear this episode. This will probably come out in a couple weeks, but I have no words. I'm not. This won't be the first time I've made fun of Dr. Oz. I mean, we all do it. It's his low hanging fruit. It's very easy to make fun of Dr. Oz just because of he's kind of like the OG grifter in healthcare. He started with Oprah and was, hawking all of these like lose weight fast diet type stuff. Like just look at Google image search Dr. Oz magazine and look at all the magazine covers. It's like follow my plan to lose 10 pounds fast. And like nothing, losing 10 pounds fast, like nothing healthy will make you lose 10 pounds fast. Like 10 pounds over like a few weeks. Okay, now we're talking. But 10 pounds fast, like 48 hours, come on. And then he's gotten into trouble doing different things. He's been sued a number of times for misrepresenting the effectiveness of fat bursting supplements on his show. It's the supplement stuff. There was like a green, what was that? A green coffee extract. Green coffee extract as a miracle weight loss drug. Supplement. Whatever he calls it. He got into legal trouble with that. So he's kind of a punching bag, as particularly in the healthcare community, but I think even outside of healthcare at all, everybody kind of realizes he's kind of a gimmick, kind of a and it's the thing is like he's a board certified surgeon. He's like I think he's a cardiothoracic surgeon, and it just kind of through his presence through Oprah and later on the Dr. Oz show where he brings up all these things. He once had an episode about conversion therapy where he had proponents of conversion therapy on to discuss the potential benefits, which there are none. It's soundly denounced by everyone, especially everyone in medicine, everyone in healthcare for sure. So he's gotten in trouble with that. It's just all these things have just added up over the years to make him not the most trustworthy source when it comes to healthcare. So that brings us to today, him being announced as the director for the Center for Medicare and Medicaid Services, which is like the largest and most influential entity in healthcare in the U.S. It's what determines everything downstream from how medical practices function, how hospitals are paid, how physicians are paid, what services patients can get covered by their both public and private health insurance. CMS affects everything. And man, it really doesn't feel good to have someone who is so susceptible to these grifting, the supplements, the things that have no basis in medicine and evidence, no evidence base for so many things that he's tried to sell people over the years. It doesn't feel good that he's going to be running like the most important healthcare entity in the U.S. So maybe he'll prove me wrong, Dr. Oz. I don't know. But I want a physician. I love the idea of a physician heading up that center, CMS. I love it. I think it definitely should be that we need more physicians in leadership positions in healthcare. But how about someone who's like practiced in the past 20 years? Like that would be great. Let's have someone who's actually practiced, seen patients, dealt with billing, dealt with reimbursement, dealt with the insurance coverage for patients under the rules of CMS, who know what it's all about. Like the guy hasn't been practicing since he jumped on Oprah's show years and years ago. Like it's been a while, and that bothers me. I want physicians there in government, like making these important decisions that affect all of us, but someone that's a little bit more trustworthy would be great. All right, let's take a break. Kristen.
What?
We got to talk about disability insurance.
Why's that?
Because I don't have it.
I know.
I wish I did.
I wish you did too.
We should have gotten it before I had testicular cancer and testicular cancer again and a cardiac arrest.
Yes, we thought we had time, but it turned out we did not.
Well, let me tell you about Pearson Rabbits.
Tell me.
This is a company founded by a physician, Dr. Stephanie Pearson, an OBGYN who had an injury, was unable to work, and is now an advocate for physicians and wants to help others avoid similar mistakes. Pearson Rabbits has decades of experience, takes its time to get to know you, your medical history, and what you need. It's not just a form you fill out on the website.
Yeah.
It's a personal connection they make, and they've helped more than 6,000 physicians get disability insurance.
I wonder if they can help you.
Maybe. To find out more and get a free one-to-one consultation, go to www.pearsonrabbits.com/knock-knock. Again, that's Pearson Rabbits, PearsonRabbitz.com/knock-knock to get more information and protect your greatest investment, you. Okay, we got the serious, like, soapboxy stuff out of the way. So if you're still listening, thank you for sticking around. I don't like to wade into politics because I want to stick to talk about eyeballs. That's really what I want to do. I really like eyeballs, but this is like when it starts to like actually potentially affect like the things that I like to talk about in my content, which is healthcare and the healthcare system and how it affects patients. Like the Dr. Oz thing is kind of important. So anyway, we'll see how it goes. All right, so let's get to eyeballs now. Okay, so looking at the feedback on our YouTube channel at Glaucomfleckens, by the way, go check it out. A lot of great comments. Thank you guys. So the post that the episode that recently came out, I talked about my ophthalmology call week. I talked about going into the hospital to see a patient who they thought might have Wilson's disease. Well, guess what? It wasn't Wilson's disease. It was something else. I'm not going to go into too many details because it's kind of a rare thing. But anyway, I talked about Kaiser Fleischer rings and everything, and you guys loved like hearing the thought process of how I approach somewhat unknown types of cases and how I come to my differential diagnosis. Well, I'm glad you guys enjoyed that because I've got another patient for you. All right, this just came up within the past few weeks. I've been trying to figure this out, and I got some lab tests that helped tremendously. All right, so this is a patient, relatively young, I would say like 60, 65. I had done her cataract surgery a few months back, and everything went great. That was really the only thing that was going on with this patient, was that she had cataract. So I did her cataract surgery. She was happy. Vision was great, doing well. And then about 2.5 months after the cataract surgery, I got a triage from one of our techs that said, your patient who you're having surgery, who you did surgery on, is having double vision. And at first, my initial thought was, what could have gone wrong during surgery to give the double vision? But then I learned that the symptoms just started a couple weeks ago, now about 3 months after the cataract surgeries were done. So that kind of rules out any like perioperative complication that could occur. But because I was thinking about it, the things that can give you double vision right after cataract surgery, there's a couple things. One would be, which is much less of an issue really, is if someone has a really dense, really bad cataract, can't see anything, it's like light perception vision out of that eye. Usually what'll happen is that eye can sometimes start to drift out. Basically, the brain just ignores that eye. It's not seeing well, so it's not going to worry about it. And you get what's called like an occlusion exotropia. The eye is not seeing anything, so the eye it's going to start drifting out. So usually it's an out type of thing. It's exotropia. The eye becomes exotropic. Sometimes you don't have that, but still, after you take that dense, severe cataract out, you put a nice clear lens in, the patient all of a sudden can see 20/20 again. Well, that's great, but the brain still has to like turn it on. Still has to figure out how to use the two eyes together again. So it's not unusual for a patient to have temporary double vision right after cataract surgery as the brain gets accustomed to seeing with two eyes again. That's pretty common. So it might be just a couple weeks, sometimes a month, but it's pretty quick. The brain will figure it out, and you'll see single again. So that's a less troublesome reason why someone can have double vision after cataract surgery. A more troubling thing would be if, in preparation for the cataract surgery, a retrobulbar block was done. So a retrobulbar block, there's different ways to provide anesthetic to the eye for surgery. So the first is you can do topical anesthesia. That's what I do. That's what most ophthalmologists do at this point, is you just give a bunch of numbing eye drops, bupivacaine, proparacaine, tetracaine, some combination of all three, get the eye nice and numbed up, and then you do your surgery. Patient doesn't feel anything. Great. Now, the downside to that is the patient can still move their eye. So that's why you got to talk to the patient sometimes during the surgery. Look at the light, look up, look down. It can be kind of frustrating for the surgeon because some patients they're not that great at keeping their eye still. Sometimes they have a little movement. Sometimes they have nystagmus. Sometimes they just don't follow commands. Sometimes they can't even really see the light because the cataract's so dense. And so they're kind of just searching. They're just moving around, moving their eye around. Most patients do just fine, and they're able to get through it maybe with a little coaching from the surgeon. We're really good at that. I'm good about managing little tiny eye movements. Sometimes there's big eye movements that do cause problems. That's not very often, though. But if someone just can't do topical because they can't keep still, they can't keep their eyes still, usually there are some surgeons who have been practicing for a long time and have just gotten used to doing retrobulbar blocks. So what that entails is taking a giant, scary needle. It's like, 4 or 5 inches. And you insert the needle on kind of below the eye, kind of outer third, through the eyelid, underneath the globe, underneath the eyeball, into the orbit. And you inject a combination of anesthetic that deadens the eye, basically. So it makes it to where temporarily the patient won't see anything, but they also can't move their eye because it renders the eye muscles, it's got some paralytic to it. So it'll make it to where You can't move your eye. You can't see. It'll give a little proptosis to the eye, bring the eye up forward. So it's a great way to do surgery for like a trainee. If you're an attending and you have a trainee that you're coaching through the surgery, a block is a great way to do it because it controls all the unpredictable factors of the surgery. It keeps the patient from moving their eye. Or if it's a patient that you're not sure they can stay still, or the topical anesthetic just isn't working for that patient, or a variety of other reasons. If you just want more control, maybe it's a tough case and you want to make sure you're accounting for everything that could go wrong, including the patient moving suddenly, then a retrobulbar block can help. I haven't done a block in years, but it's still done pretty routinely around the country. But what can happen is if you don't get the needle in just the right place, sometimes you can actually send that needle through the inferior rectus muscle. You want to try to avoid that. You don't want to hit a muscle with this because you could tear the muscle, you could cause strabismus. And so that's another reason why someone might have double vision after cataract surgery. That was the whole point of telling you about retrobulbar blocks. And also because they're a little bit scary. And so I wanted to present a little bit of excitement to the podcast here. Okay. So, why was I even talking about this? Oh, double vision after cataract surgery. Yes. So my patient, it's like, what? I'm getting on a tangent here, but it's not really a tangent. So the patient, these are the things I'm thinking of. Obviously, I know almost immediately, okay, this is not related to the cataract surgery. So what else could it be? Well, it could just be some unrelated thing, right? It's been 3 months. Other things can happen to the eye. So I'm like, all right, let's get the patient in. So I think it was the next day, the patient came in and I took a look at everything. The lenses looked great. Everything looked fine. The patient was noticing. Here's what she was noticing. She was having vertical double vision. She noticed that her eyes had been kind of red, a little bit more red than they have before. A little bit of irritation. And she feels like her eyes are like bulging out of her head. So these are all interesting symptoms like by themselves. So I do my exam and I start with checking motility. All right. So I'm looking at where the eyes are moving and they're moving back and forth pretty well. They're moving up. There's full motility. But when I do cross cover testing, so I cover one eye and then move to the other eye, there's a shift. And there's very clearly a rather large hypertropia on the right eye. So that eye is kind of displaced up compared to the other eye. And so it's kind of, going up and down like that. So she has vertical diplopia. So what could be causing that? Well, the first thing, it's probably the most common thing, and the thing that I was thinking of immediately was like, okay, could this be a fourth nerve palsy? I think I've talked about in a previous episode. There's different ways that the fourth nerve, the trochlear nerve, can be damaged. There's trauma, no trauma. This patient could be a vascular disease like diabetes, high blood pressure can cause temporary damage to that nerve and cause a vertical diplopia like this patient was presenting with. But the patient didn't have any vascular risk factors. Totally healthy, very, very healthy patient. And then I did some more testing with prisms and looking for a pattern that was consistent with a fourth nerve palsy, and I didn't see it. I'm not going to bore you with what that pattern is, but the point is, there was no pattern to the misalignment to her eyes. I could not follow a pattern that would lead me to a specific cranial nerve, a specific muscle. It was all over the place. She had double vision in almost every position of gaze, and it changed depending on where she was looking, and I could not figure out a pattern to it. When you can't figure out a pattern to double vision, it doesn't look like a sixth nerve palsy. That would be more of a horizontal diplopia, all right, where one eye doesn't move out. Fourth nerve palsy, we talked about that. Vertical, but it's very consistent with, whether or not they tilt their head and whether that makes it better or tilting it the other way makes it worse. There's a very specific pattern to a fourth nerve palsy. That wasn't it. Could it be a third nerve palsy? Definitely didn't look like a third nerve palsy. You can get a vertical diplopia with a third nerve palsy. There was no motility deficit to suggest that. There was no ptosis, droopy eyelid. There was no anisocoria. There wasn't a dilated pupil. Did not at all look like a third nerve palsy. So when there's no pattern to the double vision, there's two things that should jump right to the top of your head, and it did for me. One was myasthenia gravis. Myasthenia gravis is a disease that affects the nerve terminals. You don't get acetylcholine activating the muscles, and I didn't look up the mechanism of action. I think I might have gotten that wrong, but I do know that it causes ptosis, and it can cause what we call an incomitant diplopia. Diplopia that doesn't follow any specific pattern. The other thing that you think about is thyroid eye disease. Thyroid eye disease is also one of the more common causes of double vision out there, but it also can give a pattern that's unpredictable, that doesn't follow what the textbook says for cranial nerve palsies. So at this point, I've kind of ruled out of cranial nerve palsies, and I'm thinking, okay, myasthenia versus thyroid, could it be one of those two things? And there's also other strange things. Obviously, stroke is always on the differential. A brain tumor pressing on a nerve, that's something that you got to think about. That could be pressing either an orbital tumor pressing on an eye muscle, or pressing on probably not a cranial nerve, because you'd have cranial nerve palsy. So it'd be more like a retrobulbar orbital type tumor that could be causing problems there. Less likely. So I'm thinking myasthenia or thyroid. And then I do the rest of my exam. So now I've done my motility measurements. Now I'm looking at everything else. Pupils are good. Eye pressure's good. Vision's normal. But then looking at the eyes, it does kind of appear to me like one eye is a little bit more proptotic. It's pushed out a little bit more relative to the other eye. So I get out what's called a Hertel exophthalmometer, which is a device that can help you measure the distance one eye is compared to the other out, away from the body, away from the face. And yeah, there was a small amount of proptosis, 1 to 2 millimeters, within the range of normal for just a person with no problems whatsoever. So equivocal, right? That doesn't really point me in one direction or the other. And then I look at the eyelids. Could there be eyelid retraction? With thyroid eye disease, you get what's called lateral flare of the eyelids, all right? Because as that eye gets pushed forward from the thyroid eye disease, it causes you to have retraction of the upper eyelid, and they kind of like someone staring at you, like staring wide staring eyes, all right? That's kind of a thyroid look. And she did have a little bit of that. And then the redness. That's the other thing. So the redness to the eyes. They didn't look that red to me, but I can see, I could understand kind of what she was talking about. And with thyroid eye disease, you get injection, you get redness kind of right over the muscle insertion on the eye, because it's an inflammatory disorder, thyroid eye disease. So that's where I'm moving. I'm inching toward thyroid eye disease. All right, let's take one more break. I'll come back and tell you what I did. All right, so I did some fatigability drills, just exam techniques, which are very fancy. I have her look up for 3 minutes and see if she starts to get droopy, see if the eyelids start to get droopy. That's like a fatigue test. There was no fatigability, so nothing that would suggest myasthenia. Also, no swallowing difficulties, no breathing difficulties, no unusual weakness of the shoulder girdle or hip girdle muscles, no swallowing problem. There's just nothing to suggest a myasthenia type picture. So that's coming further down on my differential. So now I'm starting to really hone in on thyroid eye disease. So I'm thinking this might be the cause. So the things that I decided to order was, first of all, anytime you have double vision and someone's over 60, you always have to think about giant cell arteritis. Talked about that a couple episodes ago. And so I went ahead and sent some inflammatory markers, ESR, CRP, platelet count, looking to make sure that wasn't what was going on here. Those all came back normal, by the way. And I also sent her with instructions to have thyroid tests done. So a TSH, a T4, and thyroid stimulating immunoglobulin. Thyroid, I sound so smart when I say thyroid stimulating immunoglobulin. Makes me sound like an internist. I love it. So anyway, sent her to go get those done. And before I sent her away, though, for that visit, there's two things with thyroid eye disease you got to make sure, if you think that's the diagnosis. Number one is you got to make sure that there's no optic nerve dysfunction. Because what happens with thyroid eye disease is typically it's like 90% of the time it's a patient with Graves. They have hyperthyroid. And what'll happen is the eye muscles that surround the eye, they get thick and fat. They're just big old muscles. And what they can do is they can start to squeeze the optic nerve because they get so big. And that can cause vision loss and blindness. That's the first thing you got to make sure is not going on is any kind of optic nerve compression from thyroid eye disease. This patient was fine. No issues. 2015 vision, doing great. The other thing is dry eye. So because those muscles around the eye with thyroid are getting so thick and fat, it starts to push the eyeball forward. That proptosis that she was talking about. My eyes feel like they're bulging out of my head. Well, they can bulge so much that it causes exposure of the cornea because the eyelids are starting to have trouble closing over the eye. That definitely wasn't happening in her case because she didn't have that much proptosis. There's no dry eye whatsoever. So I ruled out the big bad things. So I sent her to the lab, get the GCA, the giant cell arteritis labs, the thyroid labs, and then I also ordered an MRI just because I wasn't totally sure that this couldn't be some kind of tumor or something. Maybe my measurements weren't that good. Could it be some kind of third nerve? I guess it's possible. I didn't feel comfortable with the whole picture to absolutely say that there's no intracranial process going on. So I went ahead and ordered the MRI. Would a neuro-ophthalmologist have ordered an MRI? Maybe not, but I am not a neuro-ophthalmologist. And so I did what I thought was best for the patient in trying to narrow in on the diagnosis, trying to address the big serious things. So, so far, the labs have come back. So MRI is scheduled for a couple weeks, which we may not end up doing. But the lab test showed really high thyroid stimulating immunoglobulin, as well as high thyroid hormone and low TSH. Pretty much classic Graves' disease. So I'm thinking that we caught this patient at the very, very earliest stage of thyroid eye disease before it really starts to ramp up. There's this active phase with thyroid eye disease that can last for a couple of years, and it can be brutal. It can be terrible. It can cause vision loss. So we're getting her right at the beginning, which is very exciting. Exciting because we can fix it, right? We have treatments for it. So there's obviously thyroid or steroid treatment. That's what people have done for like high dose steroids to help control the inflammation. But now there's also infusion of this medication called it's Tepezza, teprotumumab, I think is what it is. I forgot the little long name. The name I'm supposed to, the generic name. That's what I'm supposed to call things. Tepezza is the brand name. But anyway, the data around in the before and after pictures of patients with thyroid eye disease who have Tepezza is stunning. And so the problem is obviously, like every amazing medication that comes out that treats relatively uncommon diseases, crazy expensive, right? So there's a whole authorization process that has to occur. And by the way, this is not an area that I am particularly well versed in as far as like all the latest research and everything. Fortunately, in my practice, I have a wonderful partner who is an oculoplastics trained ophthalmologist. And so I'm setting this patient up to see him on Friday. And he's going to take a look and see if actually we're holding off on imaging until he sees her to see, yeah, this is like 100% Graves' disease. That's what's going on. No need for an MRI. Or maybe he might want to change it to a CT scan to look at the muscle caliber. Because I think that's probably a better option for imaging if you're looking at thyroid eye disease. If you're looking at other things inside the brain, CT is not as good as MRI. But I'm going to wait until she sees my partner before we decide on where to go with imaging. Sometimes even within ophthalmology, things are multidisciplinary. Sometimes people are shocked. How many different types of ophthalmologists are there? There's like 10. 10 of us. 10 versions of us, I should say. There's plastics, there's cornea, there's retina, there's anterior segment, cataract, there's refractive, there's oculoplastics, there's pediatrics, there's neuro-ophthalmology, there's ophthalmic genetics, there's ophthalmic pathology, there's uveitis. I think I got all of them. There's a lot. It's kind of ridiculous because the eye is only 2.5 centimeters long. So, if that. Actually, that's a pretty long eye. More like 22. Anyway, so I'll give an update, but it's like 98% sure that that's what's going on with this patient, and we're going to get her all fixed up, and it's going to be great. She's going to do well. We're early in that process, and hopefully we can stop it, slow it down, and keep the more serious adverse events that happen with Graves' disease from occurring. So that's our episode. Thank you all. I hope you enjoyed this somewhat tiny little mystery case. Just an interesting case that came up. And I'm happy to give you more as they come into my life. If you have any interesting eyeball things you want to discuss, any patients, or not a patient, if you are a patient, you want to tell me about your eye thing, I'd be more than happy to hear it. Or any other healthcare or eyeball related. I try to keep it as close to eyeball adjacent as I can whenever we talk about things, including how dry Denver is, because my eyes were having trouble. I was dumping those artificial tears on my face, I'll tell you that. So, but that's it. That's all for Knock Knock Eye for today. Thanks to my producers, Aaron Corney, Rob Goldman, and Shanti Brook. Editor and engineers, Jason Portizo. Our music is by Omer Ben-Zvi. I appreciate you all. Thank you for joining me. Knock Knock Eye and Knock Knock Eye is a human content production. We'll see you next time.
Knock, knock, goodbye.
Thanks for watching the episode. You can find more on that playlist over there. If you prefer to listen, or you just had your eyes dilated, you can binge full episodes wherever you get your podcasts. Or join the party over on Patreon, where you get early access episodes, hang out with us, get lots of exclusive bonus content. Help you subscribe, leave a comment below. Let us know what you think.